Hello, everybody. This is Laura Doherty from Functional Formularies. Thank you so much for tuning in to our webinar today, the Ketogenic Metabolic Therapy for Neurological Conditions, Hype or Hope. We have three amazing presenters today. We have Stephanie Kreitzer, who's going to start us off. Then we have Diana Leonard-Galata, and then Denise Potter will finish off the presentation. The format of this presentation is going to be a little bit different than we normally do. We're going to divide it into three 30-minute segments where Stephanie is going to talk about Alzheimer's, then Diana is going to talk about MS, and then Denise will talk about psychiatric conditions. And after each section, we will have the Q&A for that section. So first, I want to introduce Stephanie to everybody. She is a registered dietitian with 12 years experience in a variety of inpatient and outpatient settings. She is board certified as a specialist in pediatric nutrition and honed her expertise in the ketogenic diet at Children's Hospital, Colorado. There, she helped patients with various neurological and metabolic disorders and their families develop, implement, and sustain ketogenic diet care plans tailored to their needs. She enjoys working with adults and children with a broad range of medical conditions. Stephanie's passion is educating and empowering patients to achieve an improved quality of life using food as medicine. And with that, I'm going to hand the reins over to Stephanie, and I'll see everybody back for the Q&A session.
Thank you so much for that introduction, Laura. Without any further ado, let's get started talking about ketogenic metabolic therapy and Alzheimer's disease. I am a consultant, and these are my disclosures. Our objectives during my portion of this conversation are going to be to review the most recent literature on the use of ketogenic therapies in Alzheimer's, discuss the differences between using ketogenic therapy in Alzheimer's versus other conditions, and examine the obstacles to initiating a ketogenic diet in the Alzheimer's population in order to develop possible solutions. We've been using ketogenic metabolic therapy for over 100 years in the patient population with epilepsy that doesn't respond well to medications or has side effects. The ketogenic diets are typically high in fat, about 70 to 90% of calories coming from fat, moderate in protein, and very low in carbohydrates. The purpose of this macronutrient distribution is to minimize glucose utilization and instead stimulate the production of ketones to be used by the brain and other organs. It typically requires strict adherence for the use of epilepsy. However, we've adapted the term ketogenic diet to mean many different things and is used in different populations and can be more liberal in certain patient populations. Alzheimer's disease affects more than 50 million people worldwide. It's the most common neurodegenerative disorder of aging. The majority of medications and therapies that are currently available only alleviate symptoms and do not affect the course of the disease. Certain risk factors for Alzheimer's include having a family history of the disease, aging, insulin resistance, and certain genetic mutations. And interestingly, even before diagnosis or clinical symptoms, the brain in Alzheimer's disease shows a decreased ability to use glucose. This graph shows the difference in the ability of the brain's energy to use glucose over time and with people with mild cognitive impairment and Alzheimer's. Healthy young adults are able to use glucose for about 95% of their total brain fuel. About 5% of the remaining supply comes from ketones. Cognitively healthy older adults, that brain glucose uptake is decreased by about 9%. In people with mild cognitive impairment, it's decreased by 12%. And we'll see all the way over at the end, people with mild to moderate Alzheimer's disease have a decrease of about 18% in their ability for the brain to use glucose. This study refers to this as the brain energy gap. And this gap causes multiple changes in the brain, including mitochondrial dysfunction, plaques and tangles, and brain atrophy. Over time, these changes in the brain lead to clinical symptoms such as memory loss, poor judgment, difficulty completing tasks, and mood and personality changes, among others. Without intervention, the loss of brain energy continues to worsen and changes the brain and causes clinical symptoms to progress. This is where ketogenic metabolic therapies may be able to become useful, because despite the ability to use glucose in the brain of Alzheimer's, it can still process and use ketones normally. Therefore, ketones could provide an alternative fuel source to the brain in Alzheimer's in order to make up for that brain energy gap and slow the cycle. There are various ways, as those of us know who use the ketogenic diet, that we can induce ketone production with food and formula modifications. So let's take a look at some of the research that's available and the most recent. The first study we're going to discuss was a randomized, double-blind, placebo-controlled crossover study looking at the use of MCT oil when added to a typical diet versus the addition of a placebo oil. The study was done in Canada at a single tertiary care hospital, and the participants lived in the community and had mild to moderate dementia of Alzheimer's type. The crossover arm of the study included 2 phases. Each phase had a 1-month dose titration starting at 15 mLs of oil once per day, and over that 1-month titration it was increased to 15 mLs of oil 3 times per day, or the maximum dose that was tolerated. That then was continued for 3 months before the patients were transitioned to the other oil and began a new titration phase over the next month. Following those initial 8 months of the study, there was a 7-month open label phase, and the total study took 15 months. A standardized 15 ml measuring device was provided to each patient in order to ensure that everybody's 15 mLs was the same as everybody else's, which can be a trick in the keto world. Everybody's tablespoon looks different, so a standardized measuring device was provided. And then study visits occurred monthly during the randomization and crossover stages, where they looked at mental status, they did cognitive testing and quality of life questionnaires, and then every 3 months during the open label phase. A total of 20 participants went through the double-blind phase, and then 19 people participated in the open label extension. There was 1 dropout due to the admission to a long-term care facility. The average oil consumption, there was no difference between the 2 groups. It was 30 mLs per day. They were limited to go up further by compliance. Many caregivers forgot to give the midday dose of the oil. And they were also limited by tolerance. MCT oil can cause some GI upset and diarrhea, and so that was the main side effect that was seen. The average fasting BHB compared to baseline and study completion was not all that different. Neither group achieved nutritional ketosis. It was close to 0.2 for baseline and study completion, meaning that the MCT oil did not induce ketosis, but also these people did not change their diets to become more ketotic along the way. So you are simply looking at the addition of MCT oil without having to make any changes to your diet. The outcomes of this study found that a minimum dose of 15 mLs of MCT oil led to the stabilization in 3 out of 4 cognitive assessments. This study compared the results of these patients to the typical trend seen in cognition during Alzheimer's disease. And the difference, instead of the downward trend that is typically seen, is that these patients had a stabilization in the cognition. The patients who were on the MCT oil continuously for 11 months did better cognitively than those who had a break. So those that received the MCT oil in the first part of the study and then switched to the placebo oil and then put back on MCT oil did not have as good of outcomes cognitively as the group who received the MCT oil in the second arm. And superior baseline cognitive scores resulted in better outcomes, leading the study to say that there was more benefit when you provide MCT earlier in the course of Alzheimer's. The second study that we're going to review was a mouse model looking at 5X FAD mice that have a predisposition to Alzheimer's disease. The study mice received a very classic ketogenic diet, 76% fat, 3% carbohydrates, and they started this diet at 7 months of age when the mice were already showing signs of cognitive decline. There were 2 types of control mice. The first also had this 5X FAD and had a predisposition for Alzheimer's, and they were fed a standard diet, as well as wild type mice that were fed a standard diet. And that diet had 65% carbs and 12% fat. Cognitive testing was done 4 months after the ketogenic diet was initiated for all groups. The outcomes of this study were they looked at the brain anatomy as well as cognitive testing. And as far as the brain anatomy goes, there are features of Alzheimer's that were seen in these mice as well as humans, including synapse and neuronal loss, as well as amyloid beta deposits. These are seen in all patients with Alzheimer's and also seen in these mice. The results of this study showed that the ketogenic diet inhibits the loss of synapse and prevents neuronal loss in these Alzheimer's predispositioned mice. There also showed that amyloid beta deposits were significantly decreased in the mice that were predispositioned for Alzheimer's fed a ketogenic diet versus the standard diet. The study also wanted to look at what it would look like for mice to be fed this diet for a shorter amount of time instead of for 4 months. And so while ketogenic diet did improve some outcomes for over a 2-month period, it was not as beneficial as the 4-month trial was. In addition, they wanted to look at what the outcomes would be if they started the ketogenic diet later, so at 9 months instead of at 7 months. And they found no difference in spatial learning or memory. Therefore, the initiation of the ketogenic diet at a late phase is not as beneficial as starting it earlier in the course of the disease. The next study I was going to review was a assessor blinded 2-period randomized crossover trial. The subjects were 50 to 90 years old. They met criteria for probable Alzheimer's disease and had a certain rating scale on the dementia severity rating scale. They were a healthy BMI, and I think interestingly, they had to live with a trial partner who was willing to partake and help them with ketogenic diet modifications. The ketogenic diet that they used for this study was less fat than what we just saw in the mouse model. It was 58% fat, 29% protein, and 13% carbohydrates, so more of a modified Atkins ketogenic diet. The usual diet was a low-fat, high-carb diet. These patients were randomized to either receive this modified ketogenic diet first or the usual diet first. They did that for 12 weeks, and then everybody had a 10-week washout period where they received a usual diet, followed by switching of the diets for the following 12 weeks. When I read this in the study, I was quite shocked. They only provided a 1-hour diet instruction after screening. They did this by keeping the meal plans very simple and affordable. They provided recipes for both types of diets and asked participants to simply stick to the recipes that were provided instead of giving more detailed education. The participants, again, ate all meals from that plan unless they were going to attend a social event, in which case the study coordinators helped them figure out what to eat before that social event and stick to their diet. The subjects were provided a glucose and ketone monitor or meter to help them along the way, kind of know where they were at. And the diet consisted mostly of green vegetables, meats, eggs, nuts, seeds, creams, and natural oils. They did not provide any MCT oil in this study. This slide shows some of the recipes that were provided during the study. They made it, again, very attainable. They have many different types of recipes and, you know, breakfast, lunch, dinner, sides, snacks. And I think that was probably very helpful to people in this trial. Patients and their trial partners came in at baseline, at 6 weeks and 12 weeks for assessments where they assessed cognition, daily function, and quality of life. They also observed body weight measurements and some lab tests. In order to minimize the kind of stigma around certain types of diets, both of these diets were promoted as potentially healthy, and all patients were instructed to just eat until they were full instead of giving a specific calorie guidelines.
Hey, Stephanie, it's Laura. There's like some background noise. I'm sorry to interrupt you. I think it's in front of your speaker if you're shuffling the papers.
Oh, okay. I apologize.
Okay, no problem, no problem.
Okay. So both diets were promoted as potentially healthy, and they did not get specific calorie guidelines. Total of 26 patients were enrolled, 21 of which completed the ketogenic diet portion. The majority of those that dropped out at that stage simply did not want to make changes to their diet. Interestingly, it was proposed that perhaps the person living with them, their caretaker or family member, wanted them to do the diet more than they wanted to. And the average BHB while on the modified keto was 0.95. So ketotic, not in strong ketosis, but certainly producing ketones. The results of this study showed that patients on a ketogenic diet, while they didn't have an improved trend in cognition, they did have improvement in daily function and quality of life compared to those in the usual diet group. It's important to note that during weeks 7 through 11 of the study, the COVID-19 lockdown happened. And so just something to keep in mind when looking at that cognition score. It's interesting that the ketogenic diet group did see improvements before that lockdown occurred. In summary, the ketones that we provide on a ketogenic diet can be used as an alternative energy source for those with Alzheimer's, in which their brain underutilizes glucose. The MCT oil study alone that's had no diet changes showed that that MCT oil may provide stabilization and cognition with patients with Alzheimer's. And when I read through that study and other studies, my initial thought was maybe it could be useful to initiate MCT oil sort of like a medication for those patients initially after diagnosis or even early onset of symptoms to help reduce the burden and make the next steps easier while hopefully stabilizing cognition. In mice, the ketogenic diet did show a vast improvement in cognition and memory, as well as improved brain anatomy. However, would an adult with Alzheimer's disease be able to follow that strict of a ketogenic diet? It's a very tricky question. They would need a lot of support, and they themselves would need to be on board with making those diet changes. Therefore, could a modified ketogenic diet with lower ketosis be more achievable and sustainable for those with Alzheimer's under certain circumstances? Again, I think it's very telling that study, as part of being able to be enrolled in that study, you had to have somebody living with you to help you make those meals, to help you along the way and do it with you. And so I think that would be very interesting to look at in the future, and that may lead to improved daily function and quality of life compared to those on a typical diet, and maybe a more sustainable long-term modification. Areas for further research, of course, we need more studies with larger sample sizes. All of these studies were quite small. And then human studies looking at, the comparison of MCT oil or the use of exogenous ketones, diet alone, some combination of these at early onset of symptoms, and then followed for a longer period of time than a couple of months, and compared to no dietary intervention. I would love to see studies linking initial patient motivation as well as their knowledge about food in general and in comparison to the outcomes when placed on a low carbohydrate, high fat diet. And does it matter how we present these diet changes to patients? If we start with something simple and then get more complex as needed over time, does that have a difference in outcomes than if we go all in up front? The case study that I am going to present today regards a 98-year-old female with dementia of Alzheimer's type. She also had many other medical diagnoses and was fed via PEG tube. A caregiver wanted to initiate a ketogenic diet in order to improve awareness, communication, and overall quality of life. They were set on getting her on a ketogenic diet formula in order to be able to have her communicate with them about what feels okay and what hurts. You know, they really wanted to be able to have better communication because at the time she was using like grunting and moaning and groaning to communicate. When I met with the caregiver and the patient originally, she was on a standard polymeric 2.0 calorie per ml formula mixed with a wound healing supplement because she had a pressure ulcer. The initial ketogenic diet plan that we decided on was to switch slowly to a combination of a ketogenic diet formula mixed with whey protein and emulsified MCT to get to a 0.85 to 1 keto ratio and about 15% of total calories from MCT. We did this, we were able to successfully do this over the course of 4 to 6 weeks without any side effects. However, once 100% of her formula feeds were this ketogenic mixture, she started struggling with some lethargy, possible pain, although it was very, again, difficult to tell because of her low communication at that time. She also had some intermittent loose stools. Therefore, at the next visit, the caregiver had switched her to a glucose control formula mixed with whey protein and no MCT oil. They had some glucose control formula left over from a previous admission. And so he felt more comfortable using that instead of the ketogenic diet formula. And so our new plan was to, again, slowly transition to the glucose control formula mixed with whey protein and emulsified MCT to get to a 0.8 to 1 ratio with 37% of total calories from MCT. I wanted to aim a little bit higher to see if we can improve tolerance and do it very slowly. However, before we really even got started with that second keto plan, she was admitted with an infection, which was probably some of the symptoms that we were seeing. She endured a long hospital stay of about 6 to 8 weeks and then was admitted to a long-term care rehab facility where the caregiver worked with the dietitian at that facility to add in an MCT supplement to her standard polymeric formula instead of switching to a keto formula. That was the last that I had heard from the caregiver. My experience from this case study is, to encourage making small changes up front and to always consider the impacts of advanced age. This population with Alzheimer's is different than the pediatric population. They have multiple medical diagnoses in a lot of the time. And if possible, to just start with making small changes and the addition of MCT oil first, and then you can go from there based on tolerance to make sure that you are getting outcomes as well as ensuring that no harm is done. Support is integral, and maybe not so much from this case study, but all of my other experience has shown that you have to have buy-in from, first and foremost, the patient in order to be committed to making diet changes, as these do take a big commitment. It takes a big lifestyle change to change everything that you eat. And so if the patient themselves is not all in, it's going to be difficult to do this long term. If they're admitted, the staff has to be bought in, and they need to know what to look for and have somebody who's experienced with doing a ketogenic diet on the team. Here are my references. And at that, I think Laura will open up to questions.
Great, thank you so much, Stephanie. And I apologize everybody at the beginning. We had some feedback. Hopefully that got better. The joys of webinar presenting. So we learn as we go. But Stephanie, we do have a few questions that I wanted to ask you before we move on to our next speaker. The first one is, with the advanced age of this population, do you feel like the tolerance of MCT oil is different than maybe what we would use in peds epilepsy per se?
Perhaps it's different, although I don't know the exact answer to that. In this patient, obviously we didn't start with just MCT, but we did have MCT included in the formula mixture that we were doing, and she didn't have any issues until that very last stage, and in fact it wasn't likely related to the diet at all. And so I don't think that you should start with thinking that this patient population would have a difference in tolerance. But with any patient population, you're going to go slowly and start low and slow with MCT oil.
Okay, great. And the next question is, in the mouse study, were there any preventative benefits for the mice who are not genetically predisposed to Alzheimer's disease?
They did not, the mice that were not predisposition to Alzheimer's only received a standard diet in that mouse study. So they didn't receive a ketogenic diet. So they didn't look at what it would do for people who aren't necessarily, or for mice who aren't necessarily predisposed to Alzheimer's.
Okay. Maybe an interesting study for somebody to do in the future. In terms of resources, do you know of any resources, or are you and maybe the group at Advanced Ketogenic Therapies, which is where all of our speakers work or consult with today, planning on making any resources for some of these not typical uses of the ketogenic diet, or do you know of anything out there that would provide resources?
Certainly at Advanced Ketogenic Therapies, we do provide tailored needs. We meet tailored needs to patients with many different diagnoses. As far as other resources, I do know that in, again, this case study that I presented in, just the PCP themselves was very open to this conversation. And so I think while they might not be a great resource, it might be a good place to start, and then have additional conversations with a dietitian who has done this before in many patient populations. I don't know of anything else. Denise might know an answer to that too.
Denise, do you want to pop on and answer that?
Yes, super quick. Can you hear me?
Yeah.
Super quick. Metabolic Mind is a great place for resources. Metabolicmind.com, I believe, is a fabulous place where they're showcasing the latest research on ketogenic therapies for all conditions, and psychiatric, which obviously I'm going to talk about in a minute. But that would be one place. And yeah, what's really interesting is, in spite of what we use keto for, in spite of the condition, say the resources or the ed materials we use, we cross them over because it's really so similar amongst conditions. But yeah.
Great, thank you for that addition. Two or three more questions here, Stephanie, for you specifically, and then we'll move on to Diana's portion on MS. How long do you recommend Alzheimer's disease patients remain on the ketogenic diet? And this secondary question to this, how long would you recommend these patients maybe take a break from keto diet to maybe even doing like keto cycling type of mentality?
Oh gosh, well, I think we're still at the very, very beginning phases of looking at ketogenic diet in the Alzheimer's population. That I don't know that I have a recommendation for how long they should do it, but overall, using the ketogenic diet in multiple patient populations, we're going to use it until it doesn't provide benefit. Typically, we get to see that within the first 3 to 4 months if it provides benefit and what it does. And then use it if it's providing benefit. If there's side effects that we can't manage, we would need to stop. Or if the patient themselves is not going to eat it, that would be a reason for stopping as well. So I don't know how long, but I certainly think that the studies have shown that earlier that you can get this type of dietary treatment, whether it's MCT or modified or a keto diet started, the better the long-term outcomes will possibly be.
Sure. Makes sense. And for the last question for this segment, and I know a few of you have also asked questions. I'm actually going to save those to the end because they're a more general question. Any experience in using exogenous ketones in this population?
Not in this population, but exogenous ketones are very interesting. I've used it in other populations. And so again, as Denise said, we're using this across different, people with different diagnoses. Certainly you can see a boost in ketones after using those exogenous ketones, and they can provide ketones to the brain. It's just how long is that sustained after taking that exogenous ketone supplement, and can you use it with a typical diet, or then you're going to give the body glucose too? All of that is pretty unknown still about exogenous ketones. Again, I think that's where more research and just overall experience would be helpful.
Absolutely, absolutely. Well, thank you so much, Stephanie. I really appreciate it. We'll bring you on at the end if we have time for additional Q&A.
Wonderful.
For now, I am going to switch gears here, and we're going to move over to Diana. Diana, if you go ahead and unmute yourself, I will make you the presenter. Perfect. And while Diana gets her slides up and loaded, I want to introduce you. I've been fortunate to know Diana for several years. So she is a registered dietitian at the University of Virginia Health System, specializing in the ketogenic diet for epilepsy and the nutritional care of pediatric neurology patients. But recently, she has really become the expert implementing ketogenic diets for adolescents and adults with multiple sclerosis, resulting in several peer-reviewed publications. As a certified nutrition support clinician, she enjoys working with medically complex clients and patients. She has served consecutively on the board of both her local and state chapters of the Academy of Nutrition and Dietetics. She also recently presented some of her data and findings with her crew at the Global Symposium a few weeks ago. So I'm really excited to have Diana here. Thank you so much. And I will turn the reins over to you, and then I'll pop back on for Q&A.
Great, thank you, Laura. Excited to be with you today. These are my disclosures. Of course, I'm also consultant here with Nutritional Medicinals and AKT, as Laura mentioned earlier. And I'll add one small other disclosure is that I have a 2-month-old at home. I'm still on maternity leave. He's with his grandma right now, but hopefully you don't hear any distant cries. He's downstairs with her, but just gonna throw that out there just in case. So our objectives today are to talk about using keto diet in the treatment of MS, and then to get some practical tips to promote the success and reduce associated side effects with this diet. And of course, we're going to be talking a lot about the study that Dr. Brunton at UVA conducted along with myself. So I first just want to start by giving a brief overview of MS, because although most of us have probably heard of it, I didn't really know much about it until I started working in the neurology population and actually started doing the research that we did. So basically, MS is a progressive autoimmune disorder where the body attacks the myelin sheath of the central nervous system. And so if you go back to your biology classes, the myelin is that kind of insulating tissue around the nerve fiber, and it optimizes nerve signal conduction. And so when that's degraded, nerve signal conduction is poor, and there can actually be damage to the nerve fiber itself. The most common age of onset is 20 to 40 years, but it does impact people across the lifespan. It's more common in women, but again, can impact anybody. And unfortunately, it's the leading cause of non-traumatic neurological disability in young adults. So for a lot of different reasons, including the side effects of drugs used to treat MS, researchers have been looking for other treatment options. And diet has been raised as a potential adjunctive treatment because there are so many links between things that can be impacted by diet and MS. So for example, there's a link between obesity, which we know can be impacted by diet, and MS. There's a link between vitamin D status, which we know can be impacted by diet and MS, and then gut microbiome as well. And then, of course, the diet has also been looked at for a lot of other conditions outside of epilepsy. That's kind of the whole reason that we're here today. And so because it's been looked at for other neurological diseases, the thought was, maybe it could be helpful for MS. And then lastly, there was actually a large observational study by Fitzgerald et al. That showed higher quality diets, so more fruits and vegetables, less added sugars, processed grains, were associated with lower levels of disability, as well as improved fatigue, depression, pain, and cognitive impairment in MS. And those who reported following a specific diet plan had decreased chances of increased disease severity. So it's an inverse association. In addition to this, there's a lot of interest in the diet because it can be used along with medication, so that's desirable. And then another thing is that the diet is actually has the potential to modulate mechanisms that are hypothesized to influence disease evolution over time. So one example of this is the gut-associated lymphoid tissue. So of course, the diet impacts the gut-associated lymphoid tissue, and this is a very crucial tissue to the immune system. And of course, MS is an autoimmune disease. So specifically, the gut-associated lymphoid tissue plays a role in development of the host immune system, protection against pathogenic organisms, as well as maintenance of the immune response. We also know that diet breakdown products, such as ketones, can impact cell survival and function, and may also reduce the burden of oxidative stress and improve mitochondrial function and biogenesis. So why is this all important? As I mentioned at the beginning, MS is a problem of an energy deficit to the body because of an inflammatory response that ultimately leads to neuronal cell death and brain atrophy. So using a diet that can improve this energy production could largely be beneficial. So prior to our study, which I'll be talking about in a bit, the keto diet has been studied in mouse models of MS, which is called experimental autoimmune encephalomyelitis, or EAE. So all EAE is that mouse model. These studies have shown that the type of diet a mouse is on can actually impact its inflammatory pathways. So specifically, Western diets, like high sodium diets, have been shown to increase inflammatory markers, which has also been associated with more severe disease in mice. And conversely, on the right hand of the side, you'll see that anti-Westernized diets, so those are things like keto diets, caloric restriction, Mediterranean diet, intermittent fasting, these have all been shown to attenuate pro-inflammatory cytokines and reduce central demyelination and axonal injury. Okay, so that leads us into a little bit more about our specific study. So before we started our study, we wanted to see, would this be feasible? Would there be interest? So we surveyed all of the MS patients at UVA, or anybody who was willing to participate in our survey, and asked them, would they be willing to do a diet that could potentially impact their disease? On the bottom right hand, you can see that chart where over 90% in that first column said that they would change their diet. And there was not a correlation between who said that they would change their diet and any other factors like age or disease subtype, weight. So in other words, across the board, people said that they would be willing to do this. On the left side, you can see the specific diets we asked people about, and modified Atkins diet is in purple, and you can see that it was kind of among one of the more popular ones that people said that they would be willing to do. All right, so in terms of designing our study, there were a few challenges, which, as most of us know, are really common across diet studies. So the first is that, of course, a placebo or control arm would not be able to be blinded. People know what they're eating. And along with that, people in the control or placebo arm might lose interest when they know that they're kind of in that group and that they perceive that there's not going to be a huge benefit to them. There's also a lot of different ways to measure adherence in diet studies, specifically for a keto study, looking at either their ketone levels, asking what they're eating by different food frequency questionnaires or diet recalls, having them track on a smartphone. And so we kind of needed to decide which of those we were going to do. And then the last is that there's a lot of different endpoints that you can look at, and you have to decide what's kind of the most important, what's that primary endpoint for you. So ultimately, we landed on a primary objective of just demonstrating tolerability of a keto diet over 6 months, just because ours was the first study in the MS population like this in humans. And our secondary aim was to assess the impact of the diet on various clinical and serologic outcomes, which I will talk more about. All right, so now jumping more into the specifics of our study. Our study had a prospective design with a 6-month diet intervention period. We had a single arm with no control group and used an intention to treat analysis. We had 65 subjects with relapsing remitting MS, and I'm going to talk more about that number in a minute. Patients were between the ages of 12 and 55. They had to be stable on their current drug modifying therapy for greater than 6 months, and they had to have an EDSS score of less than 6. And I'm going to talk about what that score is in a minute as well. We did exclude people who had progressive forms of MS because we wanted to have a more kind of a similar population. Anybody who had used the diet for the past or within this past 6 months, anyone who is pregnant or planning to become pregnant, and then anyone who is underweight, which was a BMI of less than 18.5. People did need written permission to participate from their physician if they had a comorbid condition that could be impacted by the diet. So things like high cholesterol, a history of kidney stones, diabetes. Of course, some of these could be positively impacted by the diet, but we just wanted to make sure it was safe for them. For our sample size, we use the definition of tolerability in existing keto diet research for epilepsy, and that's defined as at least 65% of participants being able to tolerate an intervention. And so based off of that, to have an adequately powered study, we determined we needed to enroll 65 participants. So that's how we got to that number. For adherence, what we ended up landing on was photographic evidence of urinary ketosis, and that could be trace or higher for 85% of the days during the trial. All right, for our study procedures, we saw our participants 5 times. So it was baseline, 1, 3, and 6 months on the diet, and then 3 months post-intervention. There was a phone call from the dietitian at 2 weeks for additional support, just to kind of troubleshoot. In terms of what data we collected, the first was anthropometric data. So of course, height, weight, and waist circumference. We looked at body composition using a bod pod as well. We collected several patient-reported outcomes. So the first was fatigue using a modified fatigue impact scale and an MS fatigue severity scale. We looked at depression with the Beck's depression inventory, and then quality of life using a validated tool in the MS population. For our clinical outcomes, one of the more important was the EDSS. So I had mentioned that earlier, the Expanded Disability Status Scale. That's basically a neurological exam. It has a score from 0 to 10, and 0 is going to be normal, whereas 10 is death. So if you remember, our participants had to have a score of less than 6. We looked at an MS functional composite, which included several different tests, a 25-foot walk test, an auditory serial addition test to test auditory processing, and then a 9-hole peg test to test fine motor dexterity. So that's all included within that. And then we also looked at visual processing speed, visual acuity, and lastly, stamina using a 6-minute walk test. For our blood work, we kind of collected typical blood work for people on keto diet that you can see listed here, with the addition of leptin and adiponectin, which are cytokines that we're going to talk a little bit more about later. For our diet intervention, kind of as Stephanie talked about, we implemented a very similar modified Atkins diet that we would for other populations. And everybody got instruction from this from the dietitian at the visit, their first visit. So the limit was 20 grams of net carb per day. We taught people how to count those by hand, not relying on apps. And we talked about spreading those evenly throughout the day, so not building them up, at night and the evening. Participants were encouraged to have liberal intakes of healthy fats. We talked about variety being important. Specific calorie and protein goals were provided if requested, but our study was not a calorie restriction study in any way. So people did not have a calorie restriction. They didn't have a specific protein goal. There wasn't a ratio. It was that information was just provided if they needed help, like I would with any other participant or patient that I have. We did have everybody on a multivitamin with minerals, and then their calcium intake was analyzed and additional calcium was recommended if their intake was low. And then the majority of our participants were on vitamin D already, and so we just asked for them to continue the same amount. Okay, so here you can see kind of the participant pool. We screened 77 people and excluded 11 for the reasons that were listed here according to our exclusion criteria. And we're able to enroll that goal of 65. Unfortunately, we did have one person who dropped out before even starting the diet, so after the baseline visit, but before starting the diet due to a change in their personal circumstances. And so that left us with 64 people. What we found was that 53 people, or 83% of the subjects, were able to be compliant, so that positive urine ketosis for 85% of the days or greater, whereas 17% were classified as non-compliant. So the reasons for non-compliance were being lost to follow-up. That was the most common for 5 people. 3 who participated in the full duration of the study but did not have the positive urine ketones for 85% of the days or greater, so they were considered non-compliant. 2 withdrew due to side effects, which I'll talk about more in a minute, and then 1 withdrew due to a new diagnosis of Crohn's disease. But I just want to mention for that participant that they were having significant GI issues before starting the diet. We actually required clearance from their physician before starting because of these issues, and she then ended up being hospitalized and got this diagnosis. So we don't think it was at all related to the diet, since these issues were going on ahead of time. So of our participants, you can see some information about their demographics here. So their median age was fit 40, so that falls within kind of that 20 to 40 age range being the most common. We had a majority female participants. This disease is more common in women, majority white, and majority overweight. So just some information there. All right, for the side effects that I mentioned, we did find that 72% of participants reported 1 or more side effects, though these were generally minor, with the most common being constipation, which we know is very common in this diet, followed by diarrhea as the next most common. And then a very small percentage, 9%, reported nausea and weight gain, with an even smaller percentage reporting fatigue, worsening depression or anxiety, or acne. Among female participants, about 27% did also report menstrual irregularities. So that could just be any difference in like the flow, the frequency of their cycle, or irregular periods, or anything like that. All right, so now into some of our results. In this table, you're gonna see, or in the next few tables actually, you're gonna see in that kind of like salmon colored column, the baseline information. In the middle is 3 months on the diet in green, and then in blue is 6 months on the diet, so the change at 6 months. And I'm mostly going to be focusing on the change at 6 months, so that blue column, because that represents the full duration of our intervention period. So what you can see for the anthropometrics is that we did have significant reductions in BMI, waist circumference, fat mass, and resting metabolic rate. Importantly, however, fat-free mass increased. So what that tells us is that although BMI decreased, waist circumference decreased, fat mass decreased, this wasn't due to a decrease in lean muscle mass. Lean muscle mass actually increased. So that's really positive, because I know as dietitians, we worry about, rapid weight loss and how safe these diets might be. For some of our nutritional labs, just going to start with the carnitine levels actually, so that second row. And what you can see is that there was a statistically significant decrease at the 3-month mark for 24% of our participants, but this resolved by 6 months on the diet with supplementation of 100 milligrams of legal carnitine twice a day. We did see significant reductions in fasting insulin, hemoglobin A1C, triglycerides, significant increases on the other hand in LDL, total cholesterol, HDL, and vitamin D. And I just wanted to comment on the increase in vitamin D. That could have potentially been more efficient utilization of vitamin D as participants lost weight, because we know that being overweight can impact how vitamin D is metabolized. It could have also been increased compliance with their vitamin D supplementation from being in the study. So I also mentioned that we had several patient-reported outcomes that we looked at. And what you'll see is that there was a significant improvement in depression, fatigue, and quality of life after being on the ketogenic diet for 6 months. So that was all really exciting and important to us. We also collected some information about patient perceived benefits following the diet. So in the top there, you can see that almost 90% noted weight loss as a benefit to the diet. The next most common benefit noted was improvements in fatigue and improvements in stamina, both coming in at well over 50% of participants. And then improvements in MS symptoms was also noted in about 50% of participants. Less common benefits noted were improvements in sleep, concentration, and ability to exercise more, as well as improvements in depression, anxiety, and memory. All right, so just a few more things on our outcomes. The clinical outcomes, which is arguably one of the more important things that we looked at for a lot of people in this realm. And really excitingly, you can see that there was a statistically significant change or decrease in the disability score, which is that sign of neurological disability. So that was really exciting. We did see significant improvements in the 6-minute walk test, which is a measure of stamina. And while the overall change in the MS functional composite scores were not statistically significant, there was a statistical significant improvement in the 9-hole peg test. So that's that fine motor dexterity. The changes in the other tests that we looked at did not reach statistical significance. All right, and then the last outcome of the study that we're going to look at is the leptin and adiponectin levels. So as your refresher, leptin is a pro-inflammatory adipokine, whereas adiponectin is an anti-inflammatory adipokine. And so what you can see on the left side is that leptin decreased while adiponectin increased. Because leptin is primarily produced by adipose tissue, we did want to adjust for the decrease in BMI that we saw in our study. And while doing that, the change remained significant at the 3-month mark, but not the 6-month mark. And for the adiponectin, the change did not remain significant when we adjusted for BMI. So that's an important thing to know. Alrighty, so in summary, our key takeaways were that adherence to a ketogenic diet over a 6-month period is feasible for people with MS with the support of a dietitian and doctor trained in the ketogenic diet. While participants did experience side effects, they were generally minor and able to be managed conservatively. Really importantly, no subject experienced worsening of their MS while on the diet. So that's very exciting. And lastly, several measures of disability, common MS comorbidities and quality of life were improved on the ketogenic diet to levels similar to or better than what is seen in clinical drug trials. Limitations and future directions. Obviously, we didn't have a control group, so that's important to note. We would need a larger phase 3 randomized control trial to support the efficacy of the diet in MS, which excitingly we are currently submitting some grants for some bigger studies. We excluded active relapsing or progressive MS just to have a more just a more similar population. And we also noted that there's poor accuracy of urine ketones, which may not reflect true compliance. And then lastly, there's some uncertainty about whether adherence would decrease over time, so a longer than 6-month study. Just acknowledging some people who were key to making this study happen, specifically Dr. Brenton, who was the primary investigator. And then these are my references. And I think we have some time for some questions.
Great. Thank you so much, Diana. That was fantastic. We do have a few questions here. So the first one is, how specifically did you determine body composition? So you mentioned the muscle mass actually increased. What was your actual analysis?
Yeah, so it was using the BOD-POD machine, which spits out or gives us information about lean muscle tissue versus fat tissue.
And can you remind us how often they got in the BOD-POD?
The BOD-POD was just baseline and 6 months, so that was something that we didn't do at every time point. So baseline and 6 months.
Okay. And then the next question is, did you recommend any pre-made shakes or other convenience products to help with compliance on the diet?
That's a good question. So we didn't recommend anything like that across the board. Just like with any other patient population, we kind of took it on a case-by-case basis, depending on if somebody was really struggling with compliance or they really did need some help with, on the go. Certainly we would talk about those options. We were a little bit careful about some of those convenience products just in how they can impact ketosis. So I'll just briefly mention, because I'm sure we have a wide variety of people on the call, some of those convenience products have sugar alcohols or glycerin or other ingredients that for some people can lower their ketosis. So of course it's a trade-off, right? If it's going to improve their compliance to a point where they can get trace ketones, whereas they weren't getting any ketones before, well, that's a good thing. But if somebody was doing really well and then they start using those products and their ketones decrease, then that may not be so beneficial.
Yeah, definitely, for sure. It's hard to control diet, right?
Yes.
This is not specific to your study, but I think it's a great time to ask this question because I know you work with a variety of patients on a ketogenic diet. Is there a cholesterol or triglyceride level threshold, for instance, where it's be a hard stop not to try the keto diet, whether in MS or any of the other disease states you treat?
That's a really good question. And I mean, I'm definitely curious what Stephanie and Denise have to say, because I think we probably all have different cutoffs. I would say for cholesterol and triglycerides, we would hope that levels would actually improve on the diet. And so for me as a dietitian, I would kind of rely on their physician managing that to say, would you be open to us doing a ketogenic diet and seeing if we could actually get an improvement, knowing that if the levels increase to a point where, for example, for the triglycerides, that we'd be concerned about the risk of pancreatitis, that we would stop. With the cholesterol, I think it's important that you look at the cholesterol to HDL ratio as well as the LDL to HDL ratio, because cholesterol encompasses both good and bad cholesterol. So it could be that total cholesterol number is high, but they actually have really favorable ratios. So I don't have a specific cutoff for cholesterol. For triglycerides, just to throw out an answer, I would say when they start to get in the 250 to 300 range, I start to get concerned and would definitely want to do something to intervene. But I don't know if Denise or Stephanie want to jump in, or if we want them to answer that later.
Yeah, and I'm assuming, and Denise and Stephanie, you can totally unmute and jump in. I'm assuming fasting triglyceride, that would be your cutoff. Yeah.
Yes.
Okay. Denise or Stephanie, do you want to chime in on that answer?
Sorry, I was just getting back in here. Yeah, so as far as, I agree with Diana. I mean, triglycerides, unless they get pretty high, we're not super worried. I mean, and it's really kind of unusual to see them really high. You know, when someone's eating a typical diet, if they're on 24-hour feeds or something, we have issues. But yeah, and then the lipid profile, that's such a great long-term question, because when someone's doing better, and you know, you can just click off the 4, 5, 6 different ways they're doing better. If their lipid profile isn't optimal, do we tolerate that? What do we do? I mean, it's a huge, great question. I tend to tolerate a not perfect lipid profile and just work to improve it over time if the patient's having good benefit from keto.
Okay, great. Stephanie, do you have anything to add to that?
Not much, other than I agree, and I would say it's less about the baseline number and more about the change that you see over time. You're going to be monitoring that level, and if you see a drastic increase, and that's, you know, consideration for intervention versus less about what that number is up front.
Sure, that makes sense. Do any of you guys standardly in practice measure the lipid particle size?
I haven't done it in practice only because it's really really hard to find a lab that will do it, and it can be costly. I've actually tried to get it done for a couple people, and the labs have not even known what I've been talking about. But I'd love to be able to do it more in the future.
I've been able to have some people get it when they come in and they have cholesterol numbers that are concerning, and we're seeing them upwards of 300 with a total cholesterol, and that's not unusual on keto. But their HDL will be 90 or 100, so their ratio is great. But I just had someone today, literally, that we looked at that, and I thought, you know, I wouldn't even have sent her for a particle size because her ratio was okay, but her particle size, she was a pattern B or maybe like a B plus. She wasn't super, it wasn't super bad, but definitely was not entirely favorable. But she's lost 30 pounds. She's no longer depressed. She has no bipolar symptoms. She has no diabetes. You know, all these things are going well. So we're just working with her diet to improve that particle size. Gave her she's on plant sterols, omega-3s, and we're just working to improve that. But it's not, and she also had a coronary artery calcium score, which was 100% clear. So we do look at that, and we can take it to the next level, and work to improve their diet.
Sure. Stephanie, do you have anything to add to the particle size question?
No, that was a great answer.
Okay. And Diana, this is a question specifically for you. The carnitine supplementation in your study, was that 100 milligrams or 1,000 milligrams BID?
Sorry, 1,000. I'm sorry if I said 100. I think on the slide it says 1,000. 1,000 BID.
Okay, perfect. You have a young human at home, so we get it.
Yeah, sorry if I
Sleep deprivation. Very good. So Diana, thank you so much for your part. We're going to, I'm going to go ahead and make Denise the presenter for our last presenter. And while Denise is loading up her slides, I'm going to tell you a little bit about her. So Denise has been a registered dietitian nutritionist for 31 years. For the past 15 of those years, she has focused on ketogenic medical nutrition therapy. She has been privileged to speak, to train, and to educate professionals and individuals around the globe on ketogenic therapies. She strives to provide client-centered, personalized therapy, counseling, and education. Denise has a passion for helping underserved populations benefit from the keto diet. She has authored The Migraine Diet, a ketogenic meal plan for headache relief, and is the owner of Advanced Ketogenic Therapies, which is one of the largest private practice ketogenic companies in the world, to my knowledge, and she has a lot of consultants that work underneath her. So I'm going to hand it over to Denise, and she is going to talk about psychiatric conditions today. Thank
you so much, Laura. Thanks for joining us, and great job, Stephanie and Diana. It's really exciting I get really excited about this, so I'll warn you already. But as we look at ketogenic therapies, and so today I'm going to specifically talk about psychiatric conditions. Here are my disclosures. And objectives today, I want to talk specifically about KMT, and I'm going to use that as an abbreviation, in depression and also other psychiatric disorders. So not only depression, but we want to be able to name 3 potential outcomes for KMT for depression by the end. There are several types of depression, and I just want to give just a super quick background on this. We have major depressive disorder, we have persistent depressive disorder, we have depression caused by bipolar disorder. It could be included with schizoaffective disorder. You may have psychotic depression, postpartum depression, premenstrual dysphoric disorder depression. And out of these depressive types, 33% of those, at least 1/3, are treatment resistant. So, and that's, you know, strangely similar to our epilepsy statistics that you guys that are working with keto for epilepsy, you're familiar with that about 1/3 of people on anti-epileptic medications are unable to get adequate relief. And so opportunities that if they're treatment resistant with medications, you know, one of the options would be electroconvulsive therapy, which doesn't sound very fun to me. I know it does work for some people. And then just to sideline back on the major depressive disorder, major depressive, 30% of the people with major depressive disorder actually find relief, find full symptom relief. So only 30%. So we're looking at these populations and trying to find ways to help them. Globally, psychiatric conditions, here are just a few statistics. Schizoaffective disorder, 200 million people, 45 million with bipolar, 280 million with depression. So it's a global issue, and you can go back to COVID and the pandemic, and of course, things got much worse during that time. These numbers are actually, some of them pre-pandemic. Despite an array of treatment modalities, depressive disorders remain difficult to manage due to many factors, and that includes high relapse rates while undergoing the treatment, and then the unfavorable side effects of many of the medications. The costs of depression are tremendous. We have physical costs, some of the obvious where we have lost work, lost health, risk of increased diseases that happen sometimes because of medications even. There's a drastic decrease in life expectancy for patients with psychiatric conditions and mental health conditions, partly due to the increased weight and increased BMI caused by, which is kind of getting ahead of myself for the next slide, but caused by medications, decrease up to 25-year decrease in life expectancy. The financial issue with depression, I'm not going to try to give you this tremendous bunch of numbers about how much it's costing. Suffice it to say, it's millions and billions of dollars that it's costing the healthcare economy of all the countries in the world. And then individually, people have lost work time, and the companies, you know, themselves have lost work time, which will impact our economy and our families. Socially, I'd say that probably most of us on here have dealt with someone with depression if you've not dealt with it personally. And so you know full well that families are impacted by depression, that families are broken, relationships can be broken, can be damaged, education suffers or stops, and not to mention suicide. And I want to give a little shout out to my friend Julie Fast, who's an author on bipolar disorder, because she likes to refer to suicide as death by depression or death by bipolar or whatever, whatever caused it, and would like to try to stop that stigma a little bit, that this person is doing this, that it's the condition causing the unfortunate event. I want to just hit for a minute on side effects of just one of the medications that are common to use in depression and psychiatric disorders. SSRIs, common treatment, they can increase suicidal thoughts and also literally increase suicidality. So we see the numbers up. It's more prevalent with younger patients with this. It can cause weight gain, metabolic syndrome, which of course leads to is hypertension included in there, and as that causes a decreased life expectancy. These meds can in fact impact sex drive, sexual dysfunction. They can cause GI disturbances, agitation, insomnia, and the list goes on. Ketogenic therapy, of course, has its own list of side effects, and we have to look through those and decide if it's something people want to tolerate, and they have to make their own decision here. If someone asks me, what's the biggest side effect of ketogenic therapy? I would tell them constipation. I'd say that's the most common thing that happens, and of course that's annoying, but it's not a big problem. We can manage that. In psychiatric disorders, we have concerns of hypomania, insomnia, and increased energy, which that might sound great to have increased energy, but if you don't sleep all night, that's not great. Hypomania, just to define that a little bit, and I'm not a psychiatrist, but when I first saw this, I thought that meant like no mania, because you had less mania. But what it means is you're manic, but you're not entirely manic. So it's a low level of mania, so it's still not a good thing. So as people initiate on the ketogenic therapies, they may experience some of this. They may experience increased medication side effects, just like we see with ketogenic therapy for epilepsy. You may see someone have side effects from a medication when their body's in ketosis, and they didn't see those side effects of medication when they were not in ketosis. So it's something to keep in mind. Medication deprescription becomes incredibly important in this population. Other things we may see, electrolyte imbalances. Of course, when people initiate the diet very quickly, we tend to see those electrolyte imbalances. We're generally in favor of initiating the diet quite slowly, and by that I mean over a week or two versus over a day or two. You can mitigate a lot of these issues with that. We already discussed elevated lipid panel, which to me, it's definitely something we have to pay attention to, and I think our research and evidence on how we're going to deal with that and how much we should worry is many years out. And so I don't want to act like it's not a concern, but when we see many, many benefits, we have to weigh those things. And we frequently see that with labs. Say someone's on a medication that impacts their liver, and we check liver enzymes, and we see frequently with many medications that liver enzymes will be elevated for years, and that's considered acceptable. So we have to come to, over time with research, to a decision of what's acceptable with these lipids. Hypoglycemia, renal stones, I won't go much more into those. We do see that. I want to jump right into some of the literature we have on these conditions. This study came out last year, and it's really exciting when this came out. It's one of the first. It's not it's not a randomized controlled trial, but Dr. Denon in France took 31 of his patients, and he's a long-standing psychiatrist. 31 of his patients that he's worked with anywhere between 6 months and 30 years, and he put them on a ketogenic therapy in an inpatient facility. And this is a big question, because if we say that ketogenic therapy is going to work for these patients, which I firmly believe it does, then can we help them when they're in a crisis? Now, in France, I will say that they are able to go inpatient voluntarily. So not every one of these people was in a crisis and put into a facility. Some of them were, and some of them were voluntarily admitted, and they started keto in there. Now, what I'm going to show you here is just a rating scale for depression. There are 2 depression rating scales that I just want to look at specifically. The patients with schizoaffective disorder and bipolar disorder had 62 and 74% improvements on these rating scales. The people with major depressive disorder had 75 and 78% improvements on depression rating scales. On one of the scales, none of the patients any longer qualified as depressed. On the second scale, only one of them was still considered depressed, but of course not as depressed. On this therapy, their metabolic health improved, of course. All but one of the patients lost weight, and here's why I remember to say 28 out of the 31 completed, were considered in the study out of the 31. The diet was shown to be feasible and well tolerated, and over half, I'm pretty sure it's 64% of the patients went home on fewer psychiatric medications than they were admitted with. That is also to me, big information because you don't necessarily see that when someone's admitted. Virta Health is an excellent company that's been working with people with diabetes for ketogenic therapies for several years now, and they're putting out data and research and just fabulous research about diabetes and remission, and this is great. So within that, they're studying different components, and they took 262 people, and they were enrolled in virtual nutrition counseling, and which is exactly what we do. And the focus is carbohydrate restriction, and they are trying to get them into a low level of ketosis. And just side note, with something like diabetes, we aren't trying to get people in a real high level ketosis. It's not the same necessity as we see with people with psychiatric conditions. But their depressive symptoms decreased in the first 10 weeks, and that benefit continued over 2 years. And they did show that the blood ketones predicted the decreased depressive symptoms. Lastly, Dr. Ian Campbell, back in 2019, he did an online observational study to test his hypothesis to see, is ketogenic therapy of any benefit for people with bipolar disorder? And so they started there, and they analyzed data, and out of 141 people, 85.5% had reported positive impacts of ketogenic therapy. So they reported here mood stabilization, decreased depression, improved clarity of thought and speech, increased energy. And they were comparing ketogenic therapy to a diet with high omega-3s, whether it was supplemented or with food intake, and vegetarian diet. So those were the three things compared. And far and away, remission symptoms were higher for a ketogenic diet. And then fun fact, 1 week ago, Dr. Campbell's first pilot study to see efficacy and I'm losing my word here. Anyway, to evaluate is it feasible? Feasibility study. Thank you. Anyway, so 1 week ago, this came out that they wanted to assess the recruitment and the feasibility of ketogenic therapy intervention for bipolar disorder. And of course, not surprisingly, they were able to say, yes, it is beneficial. People's ketones came out to, we're at 1.3, and they don't have tons of data on outcomes in this. And in all honesty, this just came out. I haven't even fully read and digested this study yet, but I just had to mention it since we're already talking about his other one. Came out since the slides were done. Anyway, why does ketogenic therapy work? And that's a question we're still asking, even in epilepsy. And so Diana and Stephanie gave some great information on this already. So just to reiterate, we know that the regulation of neurotransmitters is probably helpful. We know ketogenic therapy improves mitochondrial function. We know that it's decreasing oxidative stress and inflammation. We know it's improving insulin levels and improving insulin resistance. So all these things are players, and why we think it's probably helping psychiatric conditions. Just like anything, there's probably not any one thing that's fixing everything. And these 4 or 5 items are probably just the tip of the iceberg. The process for starting ketogenic therapy with someone with a psychiatric condition is really very similar to how you would start ketogenic therapy for any condition. First, we're going to do a thorough medical screening with lab work, and I knew they already have put on the typical lab work, and you guys may already know which labs to test for keto, so that's not an issue. We want a thorough nutritional history. We want a thorough medical history to know what's going on with this patient. There aren't too many reasons not to start a ketogenic therapy, but there are a few, which we're not going to go in depth on that today. Next step would be to determine what diet we're going to use. There are 5 ketogenic therapies, and you may use one. You may start with one and move to another. You may start with a combination of all of the above, and that's fine too. We like to individualize therapy for people. We prepare them. Preparation and education is so important. Sometimes people fail because they weren't adequately prepared and they try to make a change in just one day, and that's really not so helpful. So we want to give several hours of preparation and education usually before we start someone on a therapy. Fun fact though is now people come to us and they've already been working on this. It's honestly pretty rare for me to start somebody from square one with keto. Usually they've done some level of it on their own. Anyway, the next thing we're going to do is initiate the diet. We tend, and we're always doing, at AKT, always doing outpatient initiations. So we tend to do that over a week or two. And then we're looking at their supplements and their standard keto supplements that, again, I'm not going to go into those here. Management and follow-up is critically important to me. I think this is where we win or lose the game, is the follow-up and support that people get early on in the diet. We tend to see people weekly, and I know a lot of places, are able to do that. But in that first couple weeks, it's really critical to give them support. So we see them weekly for a period of time, and then taper to monthly, and then eventually to quarterly. During that follow-up phase, we're of course monitoring their labs, their intake, their GI, their fluids, all of the things that you would imagine you would monitor for any patient on ketogenic therapy. Several different ways we can initiate therapy, and it could be very strict with weighed and measured meals. I love to do that even for a short period of time if someone is interested in that. We use Keto Diet Calculator from the Charlie Foundation when we want to do that. Other times we're using Chronometer or Carb Manager or something to have people track, or we're using our own materials where we're giving them specific guidelines to, how much protein, how much carbohydrate, how much fat on a meal, and we're using cups and measuring spoons to do that. And if all else fails, we're happy to look at photos of food and work from there and help them manage their diet. Supplements, again, I'm going to run by this with the exception of carnitine. I do want to mention carnitine. It's been brought up already by Diane. I know she discussed that a little bit. Carnitine, sometimes there's a recent paper that's showing carnitine is sometimes low in people with depression. And the preclinical studies, they treated the mice with carnitine and they did improve with their symptoms. We don't have clinical studies that I know of yet treating people with depression with carnitine, but it's interesting. Definitely a few of our patients with psychiatric conditions have come in with a low carnitine, and of course we treat that now either preferably with food and then sometimes with supplements when we need to. So I'll tell you about a couple of patients that I've worked with. These are, of course, I'm going to tell you, these are our great stories. This is, I won't give you his name, but this is his actual photo, a patient I've worked with bipolar 1 disorder. He's 20 years old, had a history of alcoholism. He had actually been dry for about 5 months when we started. He has excellent family support. They were doing everything to try to help him. He had been off and on homeless for the past 4 years. He'd been in at least 3 different treatment facilities, and things were not going well. He was now at a place of stability and living in a dry house where we were able to start ketogenic therapy for him. He was on 5 medications when he started therapy. He had a pretty typical college student diet, lots of carbs, lots of pizza, and no food allergies. And on his initial workup, as I mentioned, his carnitine was low and his lipid panel was not favorable, and he was eating kind of a not a great diet, and maybe that's why his lipid panel. We did do the advanced profile on him, and we found that he was pattern B. Well, we did extensive planning, pre-planning to get him started here. We started sometime in November, I think, and he didn't actually start ketogenic therapy until January, but we kind of wanted to get through the holidays and they had some vacations, and we wanted to start fresh in January. So we got him prepped. We found someone who was going to do a little help with food prep. We worked with a patient and especially with the family to get him all set because he wasn't really feeling well. And he wanted to do a rapid initiation. And so I've mentioned a couple times, I would prefer to do this over a week or two. And so we don't have, hopefully, as much hypomania, if any, and hopefully we don't have the impact on medications. But he wanted to do it quickly, so I like to do some prophylactic baking soda, sodium bicarbonate when we do that, if we have to, and make sure he's doing well with electrolytes. We give potassium salts and regular salt. And so we took care of that, and he did fine with the rapid initiation. His follow-up was weekly for the first 2 months or so, and then we tapered from there. And things were going pretty well. This is just a nice picture. Sometimes people worry that ketogenic food is not appealing and that you aren't going to eat, your diet's just going to look terrible. And people, I've heard people say, lettuce and butter and terrible things about keto. I think that idea is improving now, but I just wanted to show some of the actual meals that he ate. So really jumping fast forward here is 2.5-year outcomes. And I'll say that he started having improvements within the first, 3 to 4 months. At 5 months, he was incredibly better, almost feeling like he didn't have bipolar already by that time. His BMI was stable. His ketones at that point, a couple years out, which is just this summer, running 0.5 to 1.5. He was a little higher initially with the diet. He was running in the more like the 1.5 to 3 range, and then even one excursion up to 6 where he got a little hyperketotic. Over this 2.5-year period, with the close contact of 2 psychiatrists, he weaned 3 medications very, very slowly, and I will just say by percents, not by just cut a pill in half, cut a pill in half. It was very strategic and very cautious. His mood is excellent. He is sleeping well. He has no hypomania, no psychosis, and he's working, and his passion is sharing his story now and supporting research. We continue to do lab work now every 6 to 12 months. He's a young, healthy man, so we don't do this too frequently. His support is now very, very loose, really, honestly, almost, yearly support. And he would say he's on a modified keto diet, and he just says, I add a ton of fat to everything. He's eating out, he's traveling, he has some pre-made meals, he does some of his own cooking. It's a combination of things. We're not stuck on one exact therapy. And then the second young lady I've worked with, and I'll go a little bit quickly here. She's 30 years old. She has severe bipolar disorder, so type 1, with psychotic features. She has hallucinations all the time, constantly. She is depressed most of the time. She has tried to kill herself numerous times. Nothing's working. She's been struggling for years. She was on 6 medications at the start, and then you can see there she had many medication side effects. She told me on her initial interview that she loves sugar, which makes me, not nervous, but it just helps me to see how to work with her. And all her pre-keto labs were normal, so we just proceeded. With her education, we did things a little bit slower, and we started with small behavioral changes. We reduced sugars, we took out sweet sodas, and then she started eating a lot of keto cookies and things like that. And we had to take those things out too, because those were inhibiting ketosis. And she wanted to do once we got going, a strict plan. So we did some weighed meals for a few weeks, but at about the 2 to 3 month point, she got kind of fed up with that. And she said, I hate this diet. I don't want to check my ketones. I'm done with this. Well, that wasn't okay. So I said, throw away your scale, stop testing, just send me pictures of your food. And so we did that. And she was able to settle in. At the very next call, about a week or 2 later, she started realizing and discussing all of the benefits she was having. And just one quick note here, her doctor weaned 4 medications, not all of them antipsychotics, but at the very outset of the diet. And that was not on my recommendation. I'll just say everything went well. It was fine, but it made me a little nervous. Here's some of the meals. She was sending us pictures. She's actually a very good food photographer. And this is her actual picture. This is what's happening at 3 months for her. Her life is entirely different. She's no longer hearing voices. Brain fog's lifted. Her mood is improved. Her depression's resolved. Her concentration's improved. And many of those med side effects, of course, are resolving. So she's doing great. I want to point out here the BMI difference. She gained a little bit of weight, which is fine. She was not overweight, and she was still fine at this higher BMI. Sometimes people ask the question, they say, is this only going to work in the setting of weight loss? And I'd say no, neither of these patients had weight loss. I've had other people that have had weight loss, and it's great if they need it. Her ketones, you can see, are again in that 0.5 to 1.8 range. We're doing okay here. And what I want to just mostly point out here is that she was getting a little tired of the diet and traveling. She was kind of came back once and said, I was just eating healthy while I was in Portugal. So I want to have 1 non-keto meal a week. So you hear this, I want a cheat meal. And you say, what do? Do we give them that? Well, I hate that word. I hate cheat meal. So what I kind of negotiated was, okay, but it can't be pizza. You know, if you want to go out and you have just extra steak or you have extra vegetables, you know, fine, but we aren't going to go out and have just a, you know, really off the wall type of meal. So we were running along fine until she went to New York. And this is at about 6 months in. She was off the diet for 5 days while she was there, and then for another week once she got home. She had full recurrence of all her symptoms. So she's manic, she is psychotic, she's hearing voices, she's depressed, she's suicidal, all the things. Her family was able to get her back on therapy. And what she told me later, by the by, is it would have taken 3 to 6 months of inpatient treatment to get where she was after a few weeks. And so within 5 days, she was starting to see improvement. So this is great. Within 2 weeks, that's when I saw her. At 2 weeks, I learned about all this and I said, how much better are you? Give me a number. And she said, I'm 80% better. I said, okay, that's good. 2 weeks later, so at 4 weeks, I said, how much better are you now? And she said, I'm 90% better. Like, great, we're moving along. It's 6 weeks, we have another appointment and I see that she's not in her usual room. We're on Zoom. And I said, you know, where are you? And she said, I'm in the hospital. I said, oh my gosh. I said, what happened? What happened? And she said, oh, I'm not in the hospital. It's my family member. They're in the hospital. She said, I had to call 911. I've been working with the doctors. I'm the patient advocate. I've never been on this side of the bed before. And so here she is. And I just said, wow, you're adulting. And I can't tell you how many times I told her how proud I was of her and how proud I was that she did this therapy that enabled her to help her family. So anyway, it's happy.
Oh, Denise, I think we lost your volume. Well, can everybody still hear me?
I can hear you, Laura.
Okay.
Yes.
For some reason we lost Denise's volume, but so Denise, if you get that back here in a minute, let me know. And then maybe that's a sign because we are out of time as it is 1:30 Eastern time. I know there are a few questions that have been entered in for Denise, and I will get those answered for you and emailed to you individually with Denise. So I apologize for that. Just as a few wrap up things here to Denise, Diana, and Stephanie, thank you so much for giving your time and knowledge and expertise today for this webinar. This was really, really great. This was our first time doing an hour-and-a-half one. I thought overall it went really, really well, and there was tons of good information. So I hope everybody agrees with that. For all of our attendees, thank you for your time as well, and you will receive your certificate of attendance and a full list of all the references for all 3 presentations by the end of the day tomorrow. If you don't receive that email, please check your spam or your junk folder because sometimes that happens. And if that is not the case, please email me or reach out to us at Functional Formularies. You can email us at marketing@functionalformularies.com to get that taken care of for you. The recording will be available in the next 2 to 3 weeks on our Continuing Education Center, where we house all of our recorded webinars. So you'll get an email about that as well. But in the meantime, if anybody has any questions, please feel free to reach out to me. Thank you to all of our presenters. I can't thank you guys enough. And I hope everybody learned something. So have a great day, everybody. Denise, we'll touch base. Sorry about your volume. And we'll go from there. Thanks, everybody. Have a good one.